Next up is Dr. Thomas Lewis with a big surprise. You will never guess what the hidden cause of heart disease really is and how conventional cardiology refuses to recognize this deadly burden. This presentation gets really interesting when you discover the single most unwanted organism that cripples cellular health, attacks living tissue, and negatively impacts the heart. And finally, it's easy to understand that contaminated blood is one of the greatest threats to the cardiovascular system. So please watch to the end of this presentation with Dr. Lewis as he outlines why this problem can cause nutrient deficiencies and heart damage. So, what is it?
What is it? The major cause of heart disease, huh? Well, is it a blood pressure medication deficiency? Is it a statin deficiency? Is it inflammation? That's where functional doctors go. But what is inflammation, Jonathan? And in fact, you caused me to write a book for the Immune Defense Summit discussing chronic inflammation. And Dr. Trent, my mentor at Harvard, the ophthalmologist who really connected the link between eye diseases and cardiovascular disease, would always say to me, Tom, inflammation is a treasure of nature. We've now learned with COVID-19 that we have an infection that leads to profound inflammation called a cytokine or bradykinin storm, but it's really highly elevated cytokines and inflammatory markers. So the inflammation can kill you, but it's chicken and the egg. What came first? In COVID-19, the infection came first. Cardiovascular disease, pre-existing cardiovascular disease, is the largest risk factor for dying from COVID-19. COVID-19 is an infection. Harvard Medical School is triaging, at Mass General, triaging in-hospital COVID-19 sufferers and trying to figure out who doesn't need help, who they can help, and who is a no-hoper. And guess what they're doing? They're doing very robust blood markers, not that the standard care, not anything that the standard care is using. Cholesterol is not a part of that test, so everybody's got a cholesterol test. It's not helpful. They're doing C-reactive protein inflammation. They're doing SED rate, which is clotting of the blood and inflammation. They're doing white blood cell counts, looking at low lymphocytes from the virus. But they're also doing viral serologies and bacterial serologies. So you could ask yourself, in COVID-19, the biggest risk factor is heart disease. Why is a Z-Pak, azithromycin, helping the treatment? It's a virus. Because everybody has a pre-existing burden of infection. So if you rephrase that question and say, what is it? I would say the number one cause of coronary artery disease, heart disease, is chronic infection, stealth infection. Another word for it in the medical terminology is ectopic, which simply means, why is this there? And the last one is cryptic. In other words, cryptic means, so like with Lyme disease, you could have been infected with Borrelia burgdorferi from the tick at age 10, and then you have some sort of manifestation of that when you're 50. No different than chickenpox. You had chickenpox, but you develop shingles later in life when your immune system is crappy. So we have to recognize that we all have a burden of infection in our body. We all have a burden of organisms in our body, many of them beneficial, some of them commensal. Commensal, it's at some dose it's beneficial, at some dose it's harmful. I always tell my participants, if you have a really good politician and then they're in power too long and there's too much money, they become corrupt. My really good friend in Switzerland, Judith McCloskey, the world's #1 researcher in Alzheimer's, said I rotate probiotics for that very reason. Good can turn bad, that's commensal. But then there are plain old, nasty, dirty, outright pathogenic substances, organisms, viral and bacterial. And my main focus in cardiovascular disease is intracellular, means they live inside cells. The flu is outside, you feel sick immediately. But intracellular, bacterial pathogens. And the number one is chlamydia pneumonia. And everybody says, chlamydia, oh, I don't want to be tested for chlamydia. But it's actually mischaracterized. It's Chlamydia pneumoniae. Chlamydia pneumoniae. And this organism is a respiratory pathogen that at my age, and I won't give that away, 80% of people my age have been exposed to it. And the difference between those exposed and those who express symptoms is just the integrity of your immune system. Our white blood cells, for example. Is your white blood cell count 0? No. Because you need the patrol, the military, the militia out there taking care of these little wildfires before they take hold and go crazy. So we always have baseline immunity. And that's how I really tell if you have infection, is through the very simple test, of white blood cell count test. But yeah, this organism lives inside cells. You know, a mitochondria evolved. It's now part of our cellular structure. But evolved between a symbiosis between the cell and a bacteria. And so Chlamydia pneumonia, so that now is part of the organism, the cellular structure. But Chlamydia pneumonia can get inside the cell and mimic mitochondria and actually cause a cell to live longer than its programmed cell death, which is called apoptosis. Robert Horvitz at MIT, one of my colleagues, I like to call him a colleague, but you know he's uber. But he described programmed cell death. So every cell lives and dies. But when Chlamydia pneumonia gets inside the cell, it reprograms the genetic machinery of that cell and makes it cripple along on 3 cylinders, for example, so it can sustain itself. And then it's like the Taliban. It comes out for sneak attacks. It's not like the redcoats. The flu is the redcoats. You know it. You feel sick. But these organisms that can get intracellular and live in biofilms, these polymer-based, lipid-based structures like we have in the gum, like along the gum linings, tartar. It's a biofilm. Biofilms are everywhere in our body. And so these organisms can live there, and they're literally vampires, and they live in the vascular. So I'm going to give you a concept, Jonathan. We think about heart attack, stroke. That's a major vessel. I'm here to tell you that there's no, be a little provocative, statistically there's no big vessel disease. It's all the disease of the small vessels of the large vessels, the vasa vasorum. So I tell my participants, I will guarantee you, if you answer this question right, you know more than 99% of the cardiologists out there. If you're at home and you have you're cleaning up some debris and you're rinsing some parts or whatever, and you have a sink, and one side of the sink, two-sided sink, has a very small drain, and the other side has a large drain. Which one's going to clog first? And they all answer the small drain. I said, yep, you know more than 99% of the cardiologists, because every diagram in a cardiology office shows this plaque building up inside this large vessel. It's really building up in the small vessels that support the large vessel. You have to have a capillary within 3 cell diameters of any living cell. So a big vessel is wrapped with all kinds of small vessels, and the disease starts from the outside and works in. And all the diagrams show the disease is the inside. A cholesterol lands here and starts building up this plaque. It's completely wrong. This plaque comes from the outside and forms basically. I'll get very gross and graphic, like a zit. A zit is treated with antibiotics, very profound acne. And it's the acne vulgaris bacteria that your body's immune system responds to and creates this little capsule of cytokines from the inside out. The same thing is happening in your vessels. Okay? I said it from the outside in, rather. So this out here, where all the small vasculature is, gets diseased, and the cytokines aggregate and form this plaque inside now.
Well, again, though, physiologically speaking, the way you're describing it, the smaller vessels are actually more inside our body, and that's where the problem is developing, and it's spilling out to the outside or the outer part of a major vessel.
Right,
and
exactly.
that spilling out is what we see more, but it's not really where the problem is.
Right, and that's why Alzheimer's is underappreciated as a vascular disease, because it's happening at the capillary level, and tools like MRI can't see that. But, so Chlamydia pneumoniae is something that we all can be exposed to and actually share it. Just like COVID, we're wearing masks. And, but healthy people don't get sick from COVID. I had it back in early February. A doctor friend of mine that I do a lot of physical activity up in the Smoky Mountains with got it, and he had to be quarantined for 14 days. He had 0 symptoms. So it's like, we don't have to be fearful of some of these organisms that can cause heart disease, even periodontal disease. We all have a little periodontal disease, especially when you get older, but you don't necessarily die or have a heart attack from it because your immune system is controlling it. Naturally, you want to shut the faucet off. If you have periodontal disease, stop it. If you've been exposed to Chlamydia pneumoniae, it would be wise to get proper blood testing to see if it's starting to proliferate in your body, because organisms, if you got exposed to a heavy metal, that's it. Your body detoxifies, and hopefully you get rid of the source. But once one of these organisms gets inside, it can grow and multiply, depending on the milieu, the terrain, the health of your inner physiology.
So as we continue talking about this, Dr. Lewis, clearly then I would imagine your opinion is, if someone is told, wow, inflammation is the cause of your disease by a medical doctor, and that's all they say, from what I'm getting from you, it's too general, it's too broad, it's not specific enough. They should probably just find another doctor to work with.
Well, there's a continuum there. The traditional standard of care insurance-taking doctor is going to say your lipids are too high, your cholesterol. And cholesterol goes up. This is UC San Francisco. With inflammation and infection, your lipids go up. So we need to titrate to the inflammation. Then we need to titrate to the infection. A lot of functional doctors talk about inflammation. And certainly, when you do something that's anti-inflammatory and inflammation comes down, what you're really doing is you're supporting immunity. So your inflammation came down, but if you tested for the infection before and after, you would see that would come down too. These things aren't, these things are not death sentences. We're in a struggle, a war. It's war in there every day with these organisms. So it's all about the integrity of the immunity. But the challenging thing is, if you go in the standard of care and even get something as simple as a white blood cell count, they have a range of normal. It's like this, 3,400 to 10,800. It's normal. That's if outside of that, you have a high probability of being very sick. But, we talked about the concept of a health disease continuum. What about where are you on the continuum? And what we've shown in our research is we looked at things like white blood cell count, C-reactive protein, any number of markers, D-dimer, clotting factor, sed rate, red blood cell distribution. We can talk about some of these things, but where on the continuum of these biomarkers do they show a statistically validated increase in mortality? And when you do that, the normal ranges used in the standard of care get compressed to a very, very narrow range. And this is where we want to be. We want to be in this narrow range, not out here on this continuum. So
again, to crystallize though, before we jump off too much to something else, for someone just listening to you about white blood cell count alone, why don't you talk a little bit more detailed about that? Obviously, too high a white blood cell count, I know I'm simplifying things, but for the sake of understanding this, it's too high, it's driving up inflammation, but again, it's not really explaining to someone what's causing the inflammation, what's causing the white blood cells to go up too high. Maybe you want to talk about where it's more of a safe range to be for just white blood cell count alone?
That's perfect, Jonathan. And white blood cell counts are so clear. You go to Wikipedia, Mayo Clinic, why do they go up or why do they go down? And it's always infection. They go down in viral infections, they go up in bacterial infections in general. I'm simplifying it. But when you look at it, when you have a chronic infection like gum disease or Chlamydia pneumonia in your vessels, it's probably not everywhere. It's the concept of focal infection that Charles Mayo, the founder of Mayo Clinic, first talked about over 100 years ago, and has actually been known for like 300 years. But let's just take, rather than Chlamydia pneumoniae, which is in the vessels, let's just talk about gum disease because it's a little more easy to understand. We understand this part of our mouth, and if there's some infection in there, when it dribbles out and the white blood cells come to help, then you're not going to have like flu-like white blood cell counts wicked high, as they say in Boston. It's just going to be slightly elevated. So optimally, you want to be between 4,000 and 6,000 white blood cell count. Anything above that, you probably have a chronic infection going on. In fact, if you really want to be super optimal, it's 4,400. I've seen enough clients to know that it's 4,400. So let me just give you how profound this knowledge is, even though it's not being used in practice, because we're only focused on reactive acute care in the medical community. Here's the Women's Health Study and the Women's Health Initiative and the Nurses Health Study, conducted by Harvard, but overall over the whole country. 138,000 women monitored prospectively. And they showed a very simple thing. If you take two groups of women, one with a white blood cell count of 4,700, normal, and one with a white blood cell count of 6,700, normal. Abnormal is way out here at 10,800. And you follow them for 6 years, 50% more of these women are dead. 6,700. So what we've shown through our research is that the earliest sign of an increase in mortality from white blood cell count is actually right around 5,800, and the indication that goes up is cancer mortality. But the only thing I'll tell you is that you shouldn't just get a white blood cell count, you should get a white blood cell count with differential. There are 5 types of white blood cells, and the white blood cell count is the aggregate of all 5. But what I look at specifically are your neutrophils and your lymphocytes. Neutrophils are the most common, lymphocytes second most common. Neutrophils go up generally with bacterial infections, and lymphocytes go down with viral infections. So now your white blood cell count is normal, but your neutrophils are high and lymphocytes are low. Guess what? You have confounding comorbid infections. You have both viral and bacterial burden. And looking at neutrophil percent, anything above 60, bacterial. 40 to 60 is probably the normal range. If your lymphocytes are 1,000, it's too low. That's what they're looking for in COVID. Lymphocytopenia, low lymphocyte counts from viruses. So it's really simple, but it's also no fool's game. That's why, Jonathan, you forced me, I'll shamelessly promote, you forced me to write this book for the Immune Defense Summit, and you even named it, Uncovering Chronic Inflammation and Hidden Infections. In this book, I explain most of these pathologies and how you study them. But I think maybe the most interesting one of all, and highly misinterpreted in the standard of care, is your red blood cell distribution width, which comes with a complete blood count with differential. And what a red blood cell distribution width is very simple. It's the life and times of a red blood cell in your circulatory system. And a red blood cell, we know from A1C, because A1C is a complex between glucose and a red blood cell, is around 4 months. So a red blood cell lives for about 4 months, and it's born small and dies large. Why? Because going through corroded vessels literally inflames the outer membrane of the red blood cell, and it gets larger. So the red blood cell distribution width is literally telling you how beaten up that red blood cell, like it's us going through a hazing. We're getting slapped around and we're getting beaten up. And it literally tells you how plaqued, inflamed the inside of your capillaries are. It's very simply why if a capillary is this big in diameter, a red blood cell is this big in diameter, and to go through a capillary, a red blood cell literally has to exude and squeeze out like a worm going through soil, and it's really in contact with the outer vasculature. So what we use 2 measures: C-reactive protein, which tells you how inflamed the membrane is, and then the red blood cell distribution width to sort of show that the two are working together to see the distribution. And the number one thing that's causing the inflammation in this vascular lining is the organism Chlamydia pneumoniae.
Wow, we're talking about infections obviously being the hidden major cause of heart disease, and it's just blowing my mind as I'm listening to you. All of these infections, wherever they may be coming from, what you're mentioning now, Epstein-Barr, Lyme disease, all of these different infections, gum disease, mixing with the blood, mixing with the saliva, down into the gut, then throughout your whole bloodstream. All of this is causing sticky blood. This is what you're describing as how sludgy or difficult it is for our blood to circulate, and no doubt that's causing cardiovascular stress on our whole system, month after month, year after year.
Yeah, let me just digress to the red blood cell, but then I'm going to talk about sed rate and how it's a surrogate for the electrical system. But RDW is used, red blood cell distribution width, for anemia, and usually your RDW is 18 or above, and 25, 30, you're anemic. Okay, but above 12 and a half to say 16 or 18, that's telling you the degree of inflammation inside your vessels. And so it's a very important distinction between anemia, which really affects the red blood cells, and internally versus externally, the beating up of the outer membrane. But you're talking about sticky blood. One of the most complex people that we deal with in our practice with my medical doctors is a high sed rate. And sed rate's very simple. It's how much platelets in a tube of blood will settle and expose clear plasma. Our blood is fluid, so there's clear plasma, and then there are the platelets. Your red blood cells should defy gravity. Everything is, their physical structures, so everything's being pulled by gravity, so why don't they settle? Because the membrane is charged through the sodium-potassium pump and through ion channels, creating an electrical charge. Every cell in our body is basically a little battery. A lead-acid battery, flow of ions. Ions flowing in and out of membranes. Cholesterol is a very important part of that. We'll talk about that later. But the flow in and out creates the charge. Now there's a repulsion. So when you have a high sed rate, you have sick blood. More importantly, the cellular nature of those blood cells are discharged. And I can guarantee you every other cell in your body is discharged as well, because the lipid bilayer is contiguous to all cells. So you have very poor flow, very poor membrane structures, very poor nutrition, any number of factors. So when you can improve a sed rate, and now in the standard of care, the sed rate is 0 to 20 or something like that, sometimes 15, sometimes 25. You want to have a sed rate of 2. I put 0 to 6. I don't see an increase in mortality at 6. But really, with a LabCorp Quest sed rate test, which is dirt cheap, it's an old doctor test. You could do it on your bench. Didn't even have to send the thing to the lab. Just put the test tube on the counter and come back in an hour and see how much was settled with its millimeters. So when I say 20, it's 20 millimeter settling.
I'm sure you're familiar with this, Dr. Lewis, but it's interesting what we're talking about with red blood cells. We're talking about how, yes, of course, we have to take care of infections and minimize that risk, clean it out of the body, keep it as low as possible, keep our immune system strong so that we are reducing the risk of inflammation, sticky blood. But they were talking about how many people are not grounded. Years ago, I saw the grounded studies where they would electrically ground somebody, their feet, to the soil, to the grass, to a sandy beach, just to be grounded electrically, and how within 45 minutes to an hour, they literally started to see the red blood cells. They were sticking together, and really, you didn't have to have a major degree. Sticking together, clumpy, disgusting, and then after 45 minutes to an hour, bing, the red blood cells, like what you were talking about before, they just started getting more circular and floating around and looked so much healthier and more vibrant just by changing that alone. And how many people are fully infected in their body, not addressing that, and not grounded to the earth at all. They're messed up electrically too. You've got so many confounding factors that make the body so sticky and sick in the blood.
Well, I think that's a really good point. And, Jack Cruz, who recommends you go to the beach and stay in the water because, the salt water is a conductor. And you're also absorbing some nutrients and minerals through the skin. But the number one thing, when I look at a high sed rate and everything else looks pretty normal, I'm saying the person's just having an absorption problem in the gut. A little constipation, it's easy to absorb carbohydrates. It's difficult to absorb minerals. You have to have good, strong acid. So you have constipation, you probably don't have strong acid. You have a high sed rate, you're not getting mineral absorption. And it's the minerals flowing. The Khan Academy has some excellent videos that are highly technical on healthcare. And so you look at the sodium-potassium pump, watch one of their videos about how, sodium opens up the channel inside a cell, potassium opens it outside. So guess what? If you're potassium deficient, your cells are going to be bloated. You're going to retain water. You're going to have high blood pressure, and you're going to have a high sed rate. It's very simple physiology. It's just osmotic pressure, basic things. But how do you fix it? You improve leaky gut. You improve improper acid. You improve the microbiome. You maybe help support some of the digestive enzymes for a little while. You take some really good probiotics, prebiotics, and normally that stuff will clear it up.
Where we're talking about solutions now towards the end, which I think anybody listening carefully to what we're talking about here already, they figured this out already, but here it is, you just mentioned at the end, constipation. Again, it's not a fun topic to talk about. A lot of people don't like to talk about it with their doctors. Most doctors aren't talking about it nearly enough. If you're constipated, your gut is backing up, and you have all this, literally, crap inside, which is actually being kept outside your body, in your intestinal tract. It's constantly attacking the walls of your intestines. Now you get this thing that a lot of people are familiar with leaky gut. That's where the infections get inside the body. And so the story goes for somebody for years and years, compromised immunity, constipation, dehydrated. We talk about these problems. The solution is really just doing the opposite, fixing these things.
Right. Yeah, it's not a deficiency of some medication. But, we talked about Chlamydia Pneumonia as the major infection that underlies a lot of the vascular diseases in people. And I would say when I screen people with a white blood cell count that's just slightly off, 50% of them test positive. And what I want to tell you is that testing for these organisms is available at the major labs, LabCorp and Quest. Just people aren't ordering them and don't understand how to interpret them. I think COVID's helped a lot understanding the difference between IgG and IgM. IgM is the immunoglobulin that's sort of looking at the acute phase of the infectious process, where IgG is looking at the chronic phase. And a lot of doctors will tell you, no, that was historic, you no longer have that. But Dr. Tremp, my eye mentor at Harvard, you can see Toxoplasma gondii, which is an intracellular parasite that develops a scar, can develop a scar in the eye. You can see it's called a toxoscar. And when you test a person with a toxoscar, their IgM is normal, but it's negative, and their IgG is elevated. So that means you had it. But when you take that toxoscar, which you can access in the eye, and put it in culture, it grows. So it's not, IgG is misinterpreted as a past infection, but really what it is a dormant. You think herpes, think the chicken pox is the only thing that can go dormant? These organisms are clever. They all can go dormant. They go into actually 3 phases that Charles Stratton at Vanderbilt articulated extremely well: an elementary body, a cryptic phase, and a reticulate body. So they live in different phases. And unfortunately, if they really start proliferating and you have profound disease, then reversing that is a long and tedious but doable process. So just to give you an idea, I can do a Chlamydia Pneumonia blood test, IgG titer, for the same cost as a lipid panel. We were discussing how organisms like periodontal disease, Chlamydia Pneumonia is the one I focus on, not exclusively. Usually if you have one infection, you have comorbidity because it took hold just because you had a weak immune system So anything opportunistic that you've been exposed to and is living dormantly in your body can take hold, but Chlamydia pneumoniae tends to be the one that I see the most. And, if you're out there and you don't have a doctor to do a Chlamydia pneumoniae test, how do you know whether you have a chronic infection? How do you know your arthritis, your psoriasis, your mood disorder, your vascular, your angina is caused by an organism like this? And simple standard blood testing will reveal the truth if you know how to look at the ranges. So what we've done to improve upon that is we've created an algorithm we call your chronic disease temperature, which takes 21 biomarkers that we've looked at exhaustively for where the biomarker shows the first instance or inkling of an increase in mortality based on peer-reviewed studies and amalgamated into a single score. And I think that's appropriate because, you, Jonathan, if I met you and talked to you for 5 minutes, I'd know a little bit about you, but I don't know your story. It's like, if I look at your C-reactive protein, it's an acute phase reactant. If I bang my toe, it'll go up and it'll come down. I don't have the full picture. I have a little snapshot on it. So it's really important to know how to interpret labs, not from, oh, Mrs. Jones, this is your C-reactive protein. Oh, this is your lipid. Oh, it's how they all work together to tell a story. So, the red blood cell distribution within the C-reactive protein. One is inflammation of the vessel. One is inflammation on the red blood cell traveling through that vessel. Fibrinogen. It's a signal molecule that will recruit repair. If you cut yourself, fibrinogen will go sky high over 500. But if you just have inflammation in your vessels, fibrinogen, my endpoint for that on the high end is 285. So if it's 300, you have more repair and recovery than someone with a fibrinogen level of 250. And they usually track. C-reactive proteins, 3.5. Red blood cell distribution width is 13.5. Fibrinogen is 350. Now I have not the string quartet. We have to add another one, insulin. Insulin is probably, we measure metabolic diseases with glucose and A1C. The disease is insulin resistance. So insulin goes up first before the glucose goes up, before the A1C goes up. And as you know, Jonathan, from your metabolic summit, is that sugar in the blood is a major risk factor for inflammation and cardiovascular disease. But it really is a sign, what I say is elevated insulin is a barometer for malnutrition. And malnutrition is titrated back to repair and recovery. We all have wear and tear. It's just how good our repair and recovery is. So insulin will be up, C-reactive protein will be up, red blood cell distribution will be up, fibrinogen will be up, and oftentimes your sedimentation rate will be up. And the other things we look at, particularly for inflammation, is uric acid. Uric acid, gout. But uric acid, if you went to the top of Pikes Peak, 14,000 feet, your uric acid would go sky high. It's protective at higher levels for hypoxia. But if you're at sea level and just a regular run-of-the-mill guy eating a fairly good but not very good diet, and your uric acid is up, there's probably some hypoxia in your microvasculature. That's what uric acid is telling us. We look at lipids. We need to embrace the dark side of healthcare. And when your lipids are optimal cholesterol, and it's really a total cholesterol, which is LDL, HDL, and free cholesterol, is really optimal at around 220. That's what the international studies show, lowest risk for mortality. But when you have someone with a HDL of 70 or 80, then that's a very healthy person at 200, 220. So we look at cholesterol as a biomarker for vascular risk when you don't have familial cholesteremia, hereditary high cholesterol, when you're over 300 and when you're below 160. No one's talking about the low end of the curve, but we'll talk about that next time. So cholesterol is part of our algorithm as well, and we talked a little bit about the neutrophils, which is a subtype of white blood cell count, but just the neutrophil percent is extraordinarily telling for infection. in the lipid arena, it's not your LDL, it's not your total cholesterol, it's the arthrogenic index of plasma, which John Hopkins has published on and published in the Mayo Clinic Proceedings. And that's the ratio of your triglycerides to your HDL. It's actually the log of that. And so really what it's saying is that if you have high sugars, triglyceride being a surrogate for that, and low fat transport, that's what HDL is doing, high density lipoprotein, it's a taxi cab for fat. So basically what it's saying is you're extraordinarily sugar dependent, then you're inflamed. And when you're inflamed, you're malnourished. And when you're malnourished, you're susceptible to infection. There's almost no one I've tested that's diabetic that doesn't have a subacute infection, slightly elevated white blood cells, things of that nature. So those are the major markers that we look at. We look at kidney function. It's a shame right now that they publish, greater than 60. You're okay. You want to be between a 90 and 120. Once again, kidney function is on a continuum. And if your kidney function is below 90, there's very simple cleansing things you can do to restore your kidney function. Your kidney, you're talking about heart disease, the most vascular tissue in your body, not a lot of blood, but it's so robust in terms of blood flow, is cord of your eye. The second most vascular is your brain. There's the carotid arteries supplying blood to your brain. The third most vascular is your kidneys. And the kidney dictates, with cooperation from the brain, what your blood pressure needs to be to support what? Your brain, because it's so vascular. And your eye, because you need to see to survive. Things of that nature. So that's really what I want to talk about here is we need to understand the story of what your labs say. We produce a very detailed color-coded report called your chronic disease temperature, where we give you a single number for a constellation of labs. That makes it very easy to track. Is what you're doing causing your chronic disease temperature to go up? Stop doing that. Is your chronic disease temperature coming down? And I think you should take it every 6 months. We're dealing with chronic conditions, and so these are things that you're going to mitigate over time. It's not trying to knock out the flu.
Yeah, it makes perfect sense. Just change your lifestyle, healthier lifestyle, reduce these, I say, hidden infections, but they're not hidden anymore. Everybody's learning now from you what to look for. And then these numbers will change in a favorable way, and you don't even need the toxic medications.
No, and the blood labs provide objectivity to the subjective things you're doing to improve your health. So if you really want to have a barometer of, are you on the right path? Is this weight loss diet right? Or is this detox program right? Your blood doesn't lie. I didn't write that book, but it's a fantastic book on looking at blood labs, but it's very true.
The numbers don't lie.
The numbers don't lie.
It's great. Thank you, Dr. Lewis.
My pleasure.